Chiari malformation is something that should be studied. Why? Because it's currently believed to be rare, but maybe it's not that rare. People say it should be treated, but maybe it shouldn't be treated too much. And so it's often not understood, and personally, I don't really understand it. So that's why it's a nice thing to talk about. The Chiari malformation started when with this pathologist, Hans Chiari, who was a very interesting fellow. He talked about choriocarcinomas, he wrote about pneumocephalus, he described things in the heart, things in the GI system, and he also described a 17-year-old woman who died of typhoid, but had cerebellar tonsils which extended down from the skull into the spinal sac. So from here, we got the Chiari malformation. Now, skip forward to 100 years later, and the Chiari malformation is discussed in our basic textbooks. In the Philippines, our basic textbook is Humans, and the chapter on the Chiari malformation from 2011 to 2023 hasn't really changed that much. The definitions of the Chiari malformation on the left from 2011, on the right from 2023, and you see that they haven't changed at all. The Chiari malformation is here, and it is described as a tonsillar herniation, which extends 5 millimeters past the base of the skull. There should be no associated brainstem herniations or anomalies, and this makes your Chiari 1 malformation. So here. However, the concept has been evolving. For example, we found patients who have syrinx formation even without the cerebellum extending into the spinal cord. So since these patients respond just like a Chiari 1, they're called Chiari zeros. And we also have patients who not only does the cerebellum extend into the spinal column, we also have part of the brainstem herniating down, just like in a Chiari 2. But they behave like Chiari 1s, and so they're called Chiari 1.5s. And so this is the table taken from Yeomans of the definition of the Chiari 1, and maybe from this, we should change it to this, where a Chiari 1 is extended to a Chiari 0, a Chiari 1, and a Chiari 1.5, which are all parts of a spectrum of a disease. So what are the early takeaway points just from looking at the definition? The early takeaway points are that the Chiari malformation has largely become a radiologic diagnosis. It's diagnosed on radiology. It covers a spectrum of malformations, but the true spectrum only extends from Chiari 0 to Chiari 1.5. Chiari 2, Chiari 3, and the obsolete Chiari 4 are really different diseases and shouldn't be considered in the spectrum. Now, despite the fact that we've been studying the Chiari malformation for 100 years, a detailed understanding of the natural history is not really known. And there are lots of differentials. There's lots of things which are controversial. So if anybody who studies the Chiari malformation has to be ready to look at opinions and surveys and more opinions and on meta-analysis, because people are still evolving their understanding of the Chiari malformation. So what do we know about the Chiari malformation? For one thing, the pathogenesis seems to be fairly clear. It's believed that that there are two basic factors which cause the pathology in a Chiari malformation. One, of course, is that the cerebellum extends down and compresses the brainstem, and so you have direct compression of the brainstem, which causes damage. The other problem is that the extension of the tonsils down into the thecal sac will often lead to syrinx formation, and the syrinx causes additional damage. Now, why it's easy to understand why a cerebellar tonsil pushing against your brainstem will cause pathology, but why should there be a syrinx? Several people have theorized why a Chiari malformation should cause a syrinx. These theories were called the water hammer theory, William's suck and slosh theory, and Ball and Diane's interstitial space theory. The current theory about the syrinx formation in Chiari 1 is really the theory forwarded by Oldfield and his group. Now, they call this the systolic pressure wave theory. So what causes the formation of a syrinx in a Chiari 1? This is the normal CSF flow during the normal heartbeat. So during systole, a bit of blood rushes into your brain, and so your brain expands, and CSF gets pushed out into your thecal sac. And then during diastole, the CSF, which was pushed out, rushes back into the cranial vault. Now, when you have a Chiari malformation, the CSF cannot flow. So even though it's a small amount of CSF, it's less than 1 cc, it's 0.75 cc, each systole creates a pressure wave which forces CSF into the spinal cord through interstitial spaces. And each diastole, each time the pressure wave recedes, the syrinx fluid sloshes around and it expands your syrinx. And this happens every time your heart beats. So even though it's a small amount of CSF, the constant flow of CSF, which is impeded, the constant abnormal flow of CSF causes the syrinx to form. Now, looking at this, it's easy to see the basis of the theory of how to treat a Chiari malformation. If the problem is an obstruction, simple. Just create a bypass, remove the obstruction. And this is the key to treatment. So when we look at algorithms for treatment, again, I took these from Yeoman, they will offer two algorithms. One algorithm for asymptomatic cases, and the other algorithm for people who are symptomatic. And both of them rely on decompression of the defect. So for asymptomatic and symptomatic, it's both decompression. So let's talk about the surgery for the Chiari malformation. Now, earlier I said that the Chiari malformation seems to be a radiologic diagnosis. So when you see a Chiari malformation on a patient's MRI, is that in itself an indication for surgery? And the answer is no. There are several large studies which have shown that a lot of people, 1% of the population, which considers itself normal, actually has an undiagnosed Chiari malformation. So we're about 100 people here. Somebody here has a Chiari malformation and doesn't even realize it. So it's fairly common. And so if the Chiari alone is not an indication for surgery, how about when the Chiari is associated with a syrinx? If you have a syrinx, should you consider surgery immediately? For asymptomatic patients and for symptomatic patients, the answer seems to be yes. The prevailing opinion is yes. When you have a syrinx, you should consider surgery because the formation of a syrinx alone is a sign that your spinal cord is already being damaged, especially if the syrinx is 5 to 8 millimeters wide. Now, does everybody agree with this, that when you see a syrinx, you should automatically think about surgery? Maybe not. Some people will say that even in the presence of a syrinx, the syrinx can be benign. The history of the syrinx is benign. And a lot of people, a majority of people, will remain asymptomatic, will not have symptoms even in the presence of a syrinx. So just keep following it up. The history of the syrinx seems to be benign, and if you start a patient saying, I'm going to observe you, especially now, MRI is easy to get, so I'm going to observe you with serial MRIs, a lot of them will say, okay, that's good for the rest of my life. Now, sometimes you're worried, what about if I miss a syrinx and the patient will suddenly deteriorate? Is that my fault? Not really. It's only happened 16 times in the reported literature. So the possibility of a patient deteriorating suddenly from a syrinx doesn't seem to be very realistic. In fact, even contact sports shouldn't be stopped from a patient who has a Chiari malformation. Again, a little controversial. So if the presence of the syrinx seems to indicate that surgery should be done, how about the presence of cerebellar tonsils which descend deep into the spinal canal? Now here, again, we're talking about asymptomatic patients, patients who don't have symptoms. It seems that the descent of the tonsils is fairly important. The deeper your tonsils are, the greater the chance that you will be symptomatic, but just having your tonsils descended doesn't mean you're a candidate for surgery. Again, opinion and survey. So some more takeaway points. Should patients with a Chiari 1 and a syrinx be offered surgery? It's a reasonable option, but asymptomatic patients, maybe you can observe them. How about patients who are symptomatic? Should a symptomatic Chiari malformation be offered surgery? And sort of overwhelmingly, the answer is yes. This is the second treatment algorithm from humans, and it says that if you have a syrinx, you go to surgery. If you have cerebellar tonsils descended more than 7 millimeters, go to surgery. If they're not really descended too much, go to surgery. And if they're hardly descended at all, still think about surgery. So it's pretty liberal. So here, should symptomatic patients go to surgery? Pretty much all of the articles I reviewed said yes, symptomatic patients do deserve surgery. In fact, even scoliosis alone is considered a symptom, which is worthy of surgery. If you do Chiari decompressions for scoliosis alone, sometimes if your patient is young enough, you've already solved this problem. Now the technique. The technique is very divisive. That's why I'm waiting for Dr. Yuan's lecture. But the basic theory behind the technique, again, is simple. If there's an obstruction, remove the obstruction. Create a CSF pathway. Now, this was discovered long ago, 1930s, and it was further elucidated in the 1970s. The operation used to be quite risky. The early series actually had a 5% mortality rate, but nowadays with MRI, with proper planning, the mortality rate has gone way down. And so this is the classic technique for the Chiari decompression, which we still follow. And even there, it's a little controversial. They say that you should remove at least 2.2 centimeters wide and 2.5 centimeters high of the posterior fossa, and that if the cerebellar tonsils extend below C1, that you should unroof the entire lamina of C1. So that means another 2.2 centimeters there. So bone removal, open the dura, explore the tonsils, and then make a nice patulous closure using a graft. Now, is this controversial? Yes. One of the big controversies is how aggressively do you have to dissect into the arachnoid Now, Schmidek and Yeomans, which are again our two basic textbooks in the Philippines, say that you do not stop operating until you see CSF gushing out. And then that's the only time you can be sure that your decompression works. So do you need to open and expand the dura? Well, we consider the answer to be yes. And we're backed up. Some people say sometimes, because if you're doing a reoperation or if you have a big syrinx, then you have to do decompression. You have to expand and open the dura. But some people say, no, don't worry about it. Just open, decompress, and you'll be fine, even if you leave the dura closed. It's a confusing topic, and here are two meta-analyses, both of them written in 2021. And one of them says, open, decompress your arachnoid, wait for the CSF gush. And the other says, don't open the dura, don't mess around with the arachnoid, you'll be fine. So what's the answer? I guess we'll have to wait for the results of this trial, which is currently undergoing patient recruitment. Personally, though, I like opening the dura. Now, if the dura is not opened, how do you know that CSF is flowing? Ultrasound helps a lot, although in the Philippines, we don't have, one of the reasons we open is because we don't have ultrasounds with high enough resolution to make us convinced that we've decompressed and that we've achieved CSF flow. Splitting the dura. How aggressively do you have to split the dura? Well, some people say that you only split the dura and leave the arachnoid alone, and that this will decrease the number of complications you have, especially in terms of CSF leakage. Also, do you have to make a big patulous opening? Well, if you have an MRI, again, some people are saying no. Just make a small opening just so you're sure that you've created your bypass and you'll be okay. So instead of the big opening you see in letter B, make a small opening like letter A. And here is an example of a minimally invasive decompression where the incision is only about 1 inch long and they seem to get good decompression. Now, what about if you attack the problem directly? What if, since the tonsils, the cerebellar tonsils are obstructing the CSF flow, how about cutting out the tonsils? And this actually is the #1 operation in China, and that I understand. They have a large series of more than 1,500 cases where they say they get good results. The operations are also done minimally invasive, so the openings are rather small, and they say that the results are rather good. Now, are the results perfect? No, the results are not perfect. Even the good results are 80%, 90% satisfaction. So why does the operation fail? The operation fails in general because we haven't opened the CSF, the CSF pathway enough. We haven't dissected the arachnoid enough to allow CSF to flow, or maybe it's because there is an element of instability. Now, instability it's believed is being underestimated. Like in the Philippines, we have only fused one patient in my memory, we've only fused one patient. We just don't seem to recognize that patients have instability. Even when there's basilar invagination, our patients seem to be stable and we don't need to fuse them. This, depending on your population, this might not be so. People are recognizing more and more that the Chiari-1 malformation is associated with several factors which tell you that your spine is not stable. The brainstem can be compressed if your odontoid moves backwards and presses on the brainstem. And it's the CXA, the clivo-axial angle, might be too acute. Again, with the result that your odontoid will press against your brainstem. So now people have come up with the concept of the complex Chiari malformation. The complex Chiari malformation includes Chiari 1.5s, people who have a medullary kink, a retroflex odontoid, basilar invagination, and they say that when you have a complex Chiari malformation, the need for fusion goes up to 50%. So instead of having a simple treatment algorithm where you want to decompress, and you're done, now you have to consider decompress and think about fusion if your patient is unstable. When people talk about fusion, it's usually an occipito-cervical fusion. At least that was the opinion for several years. But not until this guy came along. This guy is Atul Goel, and of course, you know him as the inventor, the originator of the C1-C2 fusion. C1-C2 fusion. Now, should fusions now be done by C1-C2 by the Goel technique rather than the occipito-cervical fusion? If you look at the x-rays, you'll realize that C1-C2 fusion alone leaves you more mobility in your segment. It preserves more motion segments. However, in populations like ours, where we have a low volume of patients, we really appreciate that occipital-cervical fusion is effective and it's safe. Now, here's a comment taken from 2021, where I believe a German surgeon said, if one of the most experienced surgeons in this area, and he was referring to Dr. Goel himself, had to sacrifice 7 arteries with 1 fatality, what happens to your outcome if people like me, who don't do the operation very often, start trying to do C1-C2 fusions? The results might be disastrous. Although a lot of people have come up with series which say that the operation under proper precautions, with proper technique, is rather safe. So, are we any wiser about the Chiari malformation after looking at all these articles and going through them? Are we any wiser now? Well, I hope to be wiser after I listen to Dr. Yuen's lecture. Thank you very much.